welcome to the Dr. Sorin Show. This is Dr. Sorin Isparescu, and I'm really excited about our show today. We have Tricia Dickens joining us. Tricia, thank you so much for joining us.
Thanks for having me.
So Dr. Dickens is a board-certified emergency room doctor. She ran the Sandpoint Immediate Care here in Sandpoint, Idaho for about 10 years, and now you're doing locums work, and you've been traveling all over, and most recently you've been doing a lot of COVID relief. And so as I talked to you, I was like, asked you if you would come on and just tell us a little bit about what you're seeing out there, because, you know, I thank God that here in Sandpoint, we've been relatively spared from a lot of what we're seeing out there. And that's what kind of piqued my interest when I hear that you've been traveling. I said, what are you seeing out there? So let's talk a little bit about what you're doing, the different areas of the hospitals you've been at, and kind of what you're seeing.
Mm-hmm. Yeah, so I think you're right. In Sandpoint, we have been really relatively spared. And I started traveling in probably May of this year, and I went to New York City initially. I kind of got there right as it was calming down, and I was in an overflow hospital that didn't have any critical care patients. They had all been stabilized. They just couldn't go home for a variety of reasons. And so I was there for about 5 weeks. And then I have been in and out of Texas since September of 2020. I started out in Laredo, where I walked into an ICU setting, and then also in El Paso doing ICU relief work. And now I was in Odessa, Texas in December, and I'm back there again in my lovely hotel room that I've been here for 2 weeks, and will be here through the end of February.
Wow. Okay. So what are you seeing in how devastating is this, and what are you seeing in the areas?
Yeah, so it's really interesting because, you know, I see the sickest of the sick, right? I think that, so my vision gets a little bit skewed because 85%, the estimates are, of patients who get coronavirus are not going to be sick enough to require hospital care. In Odessa, the way that the system is set up is that we take care of all COVID patients on the CCU team. So we do the ones that aren't sick enough for ICU care but can't go home, so they need hospitalization, and also the ICU patients. So this particular hospital has it's the critical care team that takes care of these patients. They have one physician and one nurse practitioner. And so they typically do no more than 10 CCU beds. And only one of those beds is a negative pressure room that would be appropriate for a COVID patient. And they have a very robust OBGYN program at this hospital. So they had a NICU that they were able to convert into a COVID ICU. And there are 16 ICU beds capacity there. And also we have the capacity to take care of another 18 med-surg COVID patients. So in the time that I've been here, we've been at a maximum of 40 patients.
Wow.
Down to a minimum of about 26. Now that does include, you know, including the few CCU beds that are non-COVID that we also care for, but those are COVID patients. The ones that are in the ICU, so, you know, typically they have a maximum of 10 ICU patients. Now they have a maximum of 26 ICU patients. The vast majority of them are on ventilators.
Okay, so these are all ventilator patients. And so, one of the things I know you told me initially is that when you got to these places, you were their relief. So they were like, you were their angel that just came in, because you said these doctors have been working 24/7 trying to take care of these people.
Yeah. Yeah. If you can think, I mean, you've got one ICU pulmonologist and you have a nurse practitioner, and they're trying to care for up to 30 patients. Our average census is between 30 and 32. It's not possible. It is not possible.
How big of a city is Odessa? Sorry, I should.
You know, I haven't even looked, to tell you honestly. I don't know. It's one of the bigger cities in Texas. It's kind of Odessa and Midland together. They're two separate communities, but
Oh yeah, it's a big.
and there are two hospitals in Odessa.
Yeah, it looks like 119,000 is what Google says here. So
But you know, this is interesting, Soren, because it's kind of like a Sandpoint where we have a bigger catchment area. So Sandpoint may only be what 9,000 some population, but we have a catchment area of the whole county.
mhm.
We are receiving transfers from a lot of outlying facilities into the hospitals in Odessa and Midland.
Okay, so you guys are really two hospitals for this fairly large area.
Yeah.
Um, and then on the ICU patients, what types of patients are you seeing? Are you seeing mostly old people? Are there young people? Are you seeing kids? Everything in between?
No, we don't do any pediatrics.
Mm-hmm.
So the youngest patient that we've had was a 27-year-old
Mm-hmm.
that was on a vent. He actually walked out of the hospital. He's the only one that I have seen walk out of the, wheelchair out of the hospital that was on a vent. I did because I was curious when I was in El Paso, we had 40, basically 40 vented patients there.
Mm-hmm.
And the average age was 62.
Mm-hmm. And
So
do like the 27, do a lot of these have a lot of pre-existing conditions, or are you seeing
no,
the full
he
spectrum?
happened to be obese, but he didn't have any other medical conditions. There are people that might have prediabetes, they might have hypertension, um, but there are patients that are not on any term medication. Couldn't say, but it's not schooly people who are chronically ill get sick, go on a ventilator.
Mm-hmm. Okay, so that's interesting. So you're seeing, um, you're kind of seeing the gamut of patients there. So it's not just old people or just one group. You're kind of seeing a variety of patients there. And then I gotta ask these
Yeah,
funny.
and I would say that the the median age I would say is somewhere between the late 50s to the early 70s. And then you've got the people on the either end of that. But most of the people probably fall in that category.
Yeah, interesting. And then, but the only thing I was thinking though is still in a town of 120,000 people to have 26 patients in the ICU isn't as bad as I initially had thought, but it's still terrible. So it's hitting people, but it's still a fairly large.
But remember, we're only one of the hospitals. There's another hospital that has higher capacity
Uh-huh.
that is also past their capacity.
Oh, really?
So,
So these hospitals
yes.
are at capacity.
Oh, well, I mean, we're 206% of capacity
Yeah.
because normally we have 10 ICU beds and now we have 20.
Yeah. Now, did you say the other city is Midland? Midland's bigger. It looks like 138,000 people.
Yeah, and I don't know how many hospitals are in Midland. We have two hospitals in Odessa.
Okay, so just Odessa has two hospitals.
Just Odessa has two hospitals.
I see. And then what's the course or the progression? Now you said that one patient is the one that walked, wheelchaired out of the
Yeah,
hospital. What are you
yeah,
seeing with the other ones? It sounds like it's not good.
no. I mean, when I was in El Paso, I saw three people come off the vent and at least stay off the vent until I left. A lot of people come off the vent and then end up back on it. It's interesting, and I tell this to people when I admit them. The people that get admitted fall within a time frame from the onset of their infection.
Mm-hmm.
So, they got the coronavirus infection. Most people who get the coronavirus infection do fine. There's going to be a certain percentage, which I would estimate to be about 15%, just based on what, research I've done on it, who are going to get the COVID disease and require hospitalization. And those patients are somewhere typically 9 to 12 days that we see them, and they are sick enough to either need high flow oxygen or a Cpap machine or a ventilator. So I've kind of created in my head, if you make it past this 10 to 12 day window and you're not in the hospital on high flow oxygen or a CPAP or a ventilator, you're going to do fine. If you end up there, what happens is, we have patients that actually are 80 days, 80 days into it. And they happen, the two that are like that right now that we have on service, we just got trachs put in them. And they're, we don't know if they'll be vent dependent or not. Only time is going to tell. They still may not survive. This inflammatory process that gets set off from the COVID, I tell people when I admit them, look, buckle in. This is not I came in 2 days, 3 days on my oxygen and I'm going home. You can plan on 2 weeks in the hospital. And they all look at, and that's a minimum. That's if all goes well. And they all look at me and go, you're nuts. I'm not going to be here for 2 weeks. And routinely they're there for 2 weeks. And we kind of tell them, you're on this plateau. So you're on this plateau and you're taking 2 steps forward, 2 steps back, 2 steps forward, 2 steps back. And it changes from hour to hour. Like we'll walk through the unit and there'll be someone on a vent and you'll be like, oh my gosh, they're looking so much better. I mean, look at the numbers, and we followed the inflammatory markers. And then the next day you come through and you're like, what do you mean they're back on 100% oxygen? We just had them down to 45 yesterday,
So it's a lot of ups and downs.
Ups and down. It's a roller coaster. Buckle in. It is a roller coaster. And everybody, if they're coherent when you come in, they're all like, what's my numbers? How am I doing? What do my numbers look like? And I tell them, it's not your numbers. It's how do you feel? How do you feel today? We want to see you take 2.5 steps forward today and maybe only 2 steps back tomorrow. And they reach this plateau. Once they get through that plateau, which, I told you some of these patients are going 70, 80 days. Once they get past that plateau, if they're going to improve, they seem to improve pretty quickly. But they go home on oxygen.
Okay, that's what you're saying. So
what the long-term health consequences are going to be, don't know. Well, we just took care of a 30-year-old woman who had a huge cerebellar stroke, and we couldn't figure out what the heck was wrong. She screened negative for coronavirus, so we ran COVID antibodies, and she was positive for COVID. So we believe there was no other explanation for her stroke. We believe that was the COVID disease that affected her blood system. And I tell people, this isn't just a disease of your lungs. It's an inflammatory disease that affects every organ in your body. It's the heart, it's the kidneys, it's the gut, it's the brain, and the blood system. And who's going to get which portion of that, we have no way of predicting. And when you're in the midst of it, I don't know how you study it. You're just trying to bail water out of the boat to keep people alive.
Yeah. And so what are you doing for treatment, and what are you finding is effective? Because obviously one of the things I've learned from this is you want to not be intubated. Like you really want to do everything you can to not end up, because once you're intubated, it's not good.
It's a very poor prognosis. It's a very poor prognosis.
But my understanding, like for instance, yeah, go ahead.
These people that are on CPAP for weeks, and we have patients and what we do is we'll use CPAP at night, and then if we can transition them to a high flow oxygen or a vapotherm during the daytime, we do, so that they can eat, they can get out of bed, they can just get a break from the CPAP machine. We just intubated somebody yesterday who'd been on the CPAP for probably 10 to 12 days. And it was like, it's time. You're not moving anywhere and you are exhausted. I mean, you can just see it. They're just exhausted. Whether they will survive or not, I don't know. But there are no effective treatments. So we do corticosteroids, dexamethasone, for patients that are requiring oxygen greater than 6 liters. If they don't, we don't do it. We do have remdesivir. There are some very strict inclusion and exclusion criteria for the remdesivir. Most of the time, by the time the patients get to us, they're past the point that remdesivir would potentially be effective anyway. They're already in the cytokine storm.
Early, maybe.
Maybe. I had a lengthy discussion with our pharmacist yesterday, and he, is saying that even the remdesivir, there's not a whole lot of effective. There's not a lot of data out there saying that it's going to be effective. So once you have the COVID, it really is a wait and see, and let your body just has to ride out the storm. And if it's healthy enough to ride out the storm, you've got a good chance. If it's not healthy enough to ride out the storm, there's nothing we can do except support you while your body's trying to do what it can to heal.
Yeah.
And ride it out.
One thing I want to just clarify, what you called COVID, you're actually calling the more severe disease that needs to be hospitalized, and you're calling the just being what do you call it, coronavirus, if you're just test positive, like you got the sniffles for a couple of days and then it goes away, because that's, for a lot of people, that's what this ends up being. But you're calling COVID when they actually are sick in the hospital and need care.
Yeah, and I haven't seen that published anywhere, but that's how my brain kind of categorizes people. You got coronavirus, you got a little cold, you got better, or you got COVID.
Yes.
So I just things aren't good.
Because I just want to clarify. So for 85% of people, like you said, they go anywhere from really mild symptoms of a little sniffles, lose your taste, are annoyed that you don't enjoy your food as much as you do, to, and that's the course of most people, to being like fairly sick for a couple of weeks and really low energy. I've seen a lot of people have those types of symptoms. It's low energy that really, and don't feel like eating. And those people get hit pretty hard. But again, most of those don't need hospitalization. But then you're seeing them at the stage beyond that, which is kind of sounds like this cytokine storm where it's almost like your body's fighting itself and your immune system gets really revved up. Correct?
It's horrid. Yeah, exactly. And one thing to point out too, again, I'm seeing the sickest of the sick. There are plenty of patients that come into the emergency department who actually get discharged home from the emergency department on oxygen. They're patients that we would never, ever, ever have discharged in the past. So their oxygen saturations are 90% on up to 4 liters of oxygen.
Thanks.
Can you imagine having discharged someone like that, Sorin, when you were in medical school?
Yeah.
Heck no.
Right.
No way. But that's basically what we're down to. Like the other day, we had 0 COVID beds, 0. And they had a patient in the emergency department on 100% FiO2 on Cpap of 12 centimeters. And we're like, you're going to have to transfer them. We're getting calls in Odessa from Louisiana of providers looking for COVID beds.
Yeah.
The capacity in the healthcare system just doesn't exist. And keep in mind too, that all of the providers, the nursing staff, except for the nurses that are doing charge nursing, are FEMA nurses. They're brought in from elsewhere.
Yeah.
They're not here in Odessa. Yeah, they're brought in from all over the country: Mississippi, New York, Vermont, California. Yeah.
Yeah. So that was one of the things that impressed me on your story, because what you were telling me is when you got there, everybody was just wiped out because these people are just working continuously nonstop, trying to take care of these patients. And so you ended up being their relief. And it sounds like a lot of other nurses and healthcare workers have come in to try to help. And the hospitals have increased their capacity by, it sounds like you're getting rid of the NICU and transferring that all into adult beds. So let's talk a little bit about, as we were talking about, kind of let's shift into the causes, or what you can do, what you can't do. Let's talk a little bit about disinfectants. We talked about that. Where do you draw the line between being a psychotically, continuously using, wonderful hand sanitizer to, I know you have some opinions on that.
Yeah, I think that as just as a general in our society, we tend to be germaphobic,
Hmm.
and we actually need these healthy bacteria that live on our skin and in our gut and in our respiratory tract to help fight off the bad players. And we talked about the like the example of C. difficile colitis. Many of us are colonized with C. difficile, and our good bacteria in our gut keep it under control. And when those get out of balance or sick, then the C. difficile has an opportunity to take hold and make you sick. So I'm not a big hand sanitizer. In fact, I don't hardly ever use hand sanitizer. I will wash my hands when I'm in the hospital between patients, but uh, I don't see the necessity of hand sanitizing everything and wiping everything down religiously.
Because that's one thing that I think is very interesting. I think I got to be careful because I'm quoting from memory, but I think there was a study. Um, oh, um, sorry, the disease is multiple sclerosis or something like that.
Oh,
I think if I remember of a link to like hyper sanitizing, and you see these some of these parents, you kind of got both extremes, but and I think neither is good. I think you just need to be reasonable. But some people just wipe everything down with antimicrobial Clorox, you know, alcohol stuff. But you know,
and then they can't figure out why they can't get rid of MRSA. It's like because you don't have anybody helping you.
yeah,
If you shower 3 times a day and you strip off all the oils off your skin and you can't support a healthy microbiome and you're washing them all down the drain, then you're going to be more susceptible to opportunistic fungal infections on your skin and other bad players that can colonize your skin. It just makes you more susceptible.
and that's a very good point. So, like, bacteria is good. I mean,
Yes,
some bacteria on your skin and in your gut, it's absolutely crucial. Like your gut bacteria is crucial. And same thing with your skin. You have bacteria that sits on your skin that are your friends if you're healthy and you take care of them. That bacteria is good. It actually protects you, like you said, from some of these fungal infections. Whereas if you obsessively, put alcohol and all these other things on your skin, um, and I'm saying alcohol because you pointed out these are alcohol based. Um, the hand sanitizers are. So, so anyway, you're saying just be reasonable with, wash your hands. Don't go too crazy sanitizing everything in your house.
I would not sanitize everything in my house.
Yeah.
No.
And you mentioned, MRSA is another one. So anyway, I just think that's an important warning for people. Just remember your biome. And I love it that you're passionate because I've done this way before COVID. I've done, talks on the COVID. And like you said, there's more of them than there are of you. You have more cells in your gut bacteria that are not you that you're carrying around than you do of your body cells. So there's a lot of these
Yeah.
things. So be nice to them, eat good food, feed them the food they like,
Yeah.
and they'll be good to you versus,
Yes.
eating bad food. And then when you compound that with taking antibiotics that kills oftentimes, some of the good bacteria, then you can get the C. diff and some of those things that make you very, very sick.
Mm-hmm. Well, and I think that just disrupting the microbiome not only can influence the development of autoimmune disorders because it disrupts the lining of the gut and allows you to develop immune responses to things that you would not normally. The gut, people think of it as, oh, the gut is part of me. No, it's a conduit. The interior of our gut is still external to us,
Mm-hmm.
right? It's not part of our body. It's a conduit from our mouth through. Um, so yeah, I think we just have to recognize that it's not part of our body,
Yeah.
and we have to love it and treat them with respect and feed them well.
Yeah, totally agree. So let's just shift gear, kind of last little portion I want to cover. So what are things you can do? So it's very interesting to hear this. And well, let me ask you another question related to that as we shift. But what are some of the reasons you think we haven't been hit as hard in Sandpoint, Idaho, as maybe some of the other parts of the country that you've traveled to, like New York and, you read LA and Sounds like Texas, parts of Texas here. So what are some of the reasons maybe?
Yeah, I think that, my initial thoughts, even way back in April, March, April, were population density. And I still think that that is true to some extent. We live a very, already, just by the nature of where we are, socially distanced existence for the most part. We're not packing into restaurants and movie theaters and play theaters and things like that. So we're already have that advantage. But I also think that people in North Idaho tend to be more healthy and more cognizant of the use of pesticides and other toxins. We're not as exposed to toxins as people in more dense areas, and just eat better food.
Yeah. Yeah. We talked about that a little bit, but a lot of this prepackaged and fast foods, uh, at
It's
least
not food.
and not food. And I'm the vegetarian, so I always talk about that. But even people up here that aren't vegetarian, they're eating, like you mentioned, grass fed, which is what cows are supposed to eat, right? you know,
Right.
they're not
Exactly.
fed grains, they're
Exactly.
actually eating grass and hay and things like that. And so they're eating, even if the meat they're eating is like a healthier meat, or they're eating a lot of game meat. There's a lot of hunters up here. So not these like mass farms, pesticide, hormone filled, antibiotic filled,
Yeah.
mass production places.
Yeah, yeah. And I would take it a step further to say, in terms of just food production, and we talked about a microbiome on our skin, there's a microbiome in the dirt as well.
Mhm.
And when you start putting all these pesticides and just blanketing and trying to grow monocultures where you have to use the pesticides in order to maximize the yields on your crops, it's unhealthy for the soil, which is unhealthy for the plant. And even the plant that you grow in that environment is not going to be as healthy for us to eat. So it's all boils down to the bacteria.
Very interesting. I hadn't thought as much, but you're absolutely right about the microbiome and the ground. You're right. Because they
Yeah.
talk about when you grow using organic methods and you have healthy dirt and you're putting all the nutrients in, um, you have much healthier soil. We used to live
Mm-hmm.
out in the desert, and they didn't, and they would farm that land a lot. And we bought a house that was um, on that land. I remember that had a lot of bugs, a lot of
Mm-hmm.
bugs. So you would always have to, spray pesticides. But, that's like they're getting out in the desert, they're getting, 5 crops a year. So they're just throwing some, very few nutrients, whatever, to get it to grow. And then the next one. So they're never really kind of putting in that organic way. So that's a great point. I didn't think about that.
Mm-hmm. Mm-hmm. Yeah, that's another one of my passions is soil health.
Yeah, well, I hadn't thought about that in in the plants. So then when you eat obviously like organically grown food where they actually are not this mass farm where they're, composting, and especially if you do it yourself, you're putting all this love and good nutrition into the ground, not just like 3 nutrients, which is I think what these mass farms do, and they buy liquid and then they spray a bunch of glycophosphate based chemicals that kill everything else. Uh,
And just add sodium, phosphate, and potassium, and you'll be fine, right?
Well, are those the 3 they add? Because I know they said there's 3. They add like 3 chemicals, and then you get these
Yes.
big, beautiful plants. But again, when you buy this big, beautiful looking, tomato, and then you get the ugly tomato from the farmer, from local farmer, locally grown, the taste, there's no comparison. I mean, you
Yeah.
can
Well,
taste.
and yeah, there are nutritional studies too that look at the nutritional value of the food raised with chemicals versus organic, or I would even say regenerative or sustainably, that is higher. Now, not all organic is healthy either, because they may be using artificial fertilizer input as well. And so there's even a difference in the organic nutritional content of organic food. So it's really good, like you said, grow your own, make your compost, grow your own food, and it will be it will also be grown with love, which I think energetics of food is important as well, but that's a whole nother topic.
There you go. Well, I love what you're saying. So that's one of your, because the last part I want to do is kind of what to do. And so it sounds like one of the things you're recommending is eat real food,
Yeah.
which means, food that's been, if you, organically grown or as organically as you can get it. And uh,
Yeah.
again,
Yeah.
great.
So, we don't have any effective therapies for COVID. So we do use dexamethasone, which is a steroid medication trying to blunt the immune system, but it's not necessarily effective, right? And we're just doing what we think we can. And we only use that with patients who are requiring 6 liters of oxygen, because we know that they have crossed this line into cytokine storm. So, the things that there is no treatment for COVID, but the things that can help you would be to be healthy if you got it. And that's not something that you can go, gee, I think I'm going to go to a party tonight. So I'm going to go run a mile and eat some broccoli tonight and drink 8 ounces of water. And it's going to help me be healthy. That's something that you had to be doing leading up into the exposure.
Yeah. And that's,
So,
I'm totally in agreement with. It's like you don't try to get healthy really fast. Hey, better late than never, but the best plan is just to
yeah.
eat healthfully, exercise, get proper sleep. You mentioned drink water, not soda, right? Just hydrate yourself properly without all the chemicals. So,
Yeah.
uh, by the way, just one little thing I know, guys. Hydroxychloroquine and ivermectin. Your thoughts on those?
I wouldn't take them.
Okay.
There are no, so, and in fact, I looked this up because I knew you were going to ask me about ivermectin because that has become the thing. And I will tell you that for the 2 weeks that I have been here, every single patient that we have admitted to the COVID unit has been taking ivermectin. So that is the new hydroxychloroquine because when I was in New York, every single patient had taken hydroxychloroquine. So neither one of them have any proven benefits. I've heard people say, well, there's all these studies. So I just went and looked this afternoon to see, are there really any studies? I could not find them if they exist. There is a randomized controlled trial study being done right now, but it's not completed. And the studies that are out there that may show benefit are like anecdotal studies or retrospective studies where you can't cohort the patients into, giving one of them placebo and one of them ivermectin. So, you have to compare it. And there's one other study that compares ivermectin and doxycycline with hydroxychloroquine and zithromax. There's no placebo arm. So you don't know how well a patient would have done, a similar patient would have done with no treatment. And in my experience, it's just a matter of the body having to reset itself. And we have ways that we can support you while you do that. But, give you nutrition. We can, through an IV or through an NG tube, we can put you on the ventilator or give you oxygen. And that's about it. And blood thinners. We do routinely use blood thinners because these patients, they clot. I've seen amputations, seen heart attacks. A vast majority of them, once you go on the vent, if you're on the vent for any period of time, you end up on dialysis too, just because of the clotting issues associated. And these are not like a pulmonary embolus. It's not an embolus that develops and breaks loose. It's in situ clotting in the small vessels of whatever organ, and the only thing that I've been able to kind of figure out, just like the woman had the stroke, that was an in situ clot. It wasn't an embolus.
Interesting.
So,
Well, I've really appreciated your time and your expertise and kind of hearing from the front lines and you're literally directly on the front lines there. And it's a whole different picture there. And I think we've been blessed out here. And so I think the take home message to the listeners is, for sure, this is a real thing. A lot of people are dying. It's very serious. But, you know, what you can do is what you should have been doing all along is stay healthy, eat right, exercise, you know, don't live in highly populated areas, wash your hands, uh, you know, a reasonable amount of time. Don't go crazy and wash the skin off your hands. Um, any other
Yeah.
closing thoughts you have?
No, I really appreciate you giving me the opportunity to tell my story, because a lot of people still, and many of my friends, think that it's not as bad as they said it was going to be. I'm like, well, in North Idaho, maybe not, but it is as bad as they said it was going to be.
Yeah. Well, I really appreciate you taking a few minutes to chat with us on that, Tricia. Again, thank you for joining us.
All right. Have a good night.
You too.